My name is Brian Wood, Medical Director for the Mountain West AETC ECHO. Welcome to this week's session, and I will turn it over to today's speaker.
Today's topic, as we mentioned, is HIV medications. We're going to look at dietary and drug-drug interaction issues, and I have no conflicts of interest to report. Our objectives are to briefly review the effects of different types of diet on ARV bioavailability, which I think is pretty interesting. And then we're going to take a look at mechanisms that are commonly associated with drug-drug interactions in general and with ARV drugs in specific. We'll also look at just a couple of common drug interactions that we see and that are going to be a part of the presentation. Okay, so what I've done is to try to take a closer look at ARV bioavailability and diet. And to do that, I've created tables for every therapeutic class looking at how different types of diet affect the availability of those drugs. I've referenced the FDA prescribing information. I've referenced micromedics, clinical pharmacology, and facts and comparisons as references. And you can see one of the columns in the table denotes the FDA recommended administration guidance, either plus or minus food, or plus food, or minus food. And then there's 4 columns that describe the effects that different dietary conditions have on the bioavailability of medications. And you can see some numbers that are without a plus or a minus. Well, like under fasting, that denotes absolute bioavailability. And for some drugs, we know that. For some, we don't. And then the numbers with a plus or minus, that denotes change in AUC under different dietary conditions. And for this particular first class, for the NRTIs, you can see that food has very little effect on the NRTIs. Most are fairly bioavailability in a fasting state, except for TAF. TAF seems to have a markedly improved bioavailability with a high-fat meal. It's significant to note, of course, that TAF is indicated for Hep B and not HIV, but for the sake of completion, I added it to this table. The next slide, of course, was the combos, NRTI combos, and that is very similar in that most of those medications are bioavailability in a fasting state, and you don't really need to take food. Interesting thing about FTAF is that you do see a significantly improved availability of TAF in that combo product. However, the FDA guidance is still to give it with or without food. Among the NNRTIs, you can see nevirapine is really the only NNRTI without specific food intake requirements because it has a fasting bioavailability of greater than 90%, and even when you do challenge it with different dietary conditions, it's really not affected. You can see also a significant drop in bioavailability with both etravirine and rilpivirine, as we're well aware with rilpivirine. I guess most of us know the significant adverse effects of fasting with etravirine, so it's important that it also be taken with food. And it's significant that I think when you take rilpivirine with a protein supplement, you can see there's actually a greater decrement in bioavailability, a minus 50 versus minus 40% fasting. This is the protease inhibitors. It's important to notice the importance of food with unboosted atazanavir. Without food, it does not have very good availability. Notice also the difference that high-fat meal makes with cobicistat-boosted darunavir. It's important to realize the role of food to improve with protease inhibitors is by far to improve tolerance, mostly, I think, regardless of its effect on bioavailability. And the only protease inhibitor without a specific food recommendation is lopinavir-ritonavir, but in practice, we generally recommend that you take that medication also with food. As far as the integrase inhibitors go, I think this is probably the most interesting class when it comes to dietary changes. You can see a very positive impact of a high-fat meal on all the integrase inhibitors, except for the high-dose raltegravir. Very significant positive changes in AUC. It's interesting to note, though, that the FDA guidance still says you should give them with or without food. Notice also the negative impact of a low-fat meal on both of the raltegravir regimens. Significant. There's a minus 46%, minus 42% change in AUC with those two drugs. The twice-daily raltegravir actually demonstrates a high inter- or intra-patient pharmacokinetic variability compared to the integrase inhibitors. And that's actually evidenced by a highly variable plasma concentration when one is taking a stable twice daily regimen. In pharmacokinetic terms, this variability is described as a coefficient of variation, and which for twice daily raltegravir can sometimes be greater than 200%. In contrast, if you look at the coefficient of variation for dolutegravir, it's more on the order of 25 to 50%. I think this table also demonstrates how food further increases this PK variability for twice daily raltegravir, where changes in AUC ranging from a positive 111% down to a negative 46% AUC. It's also noteworthy that this new high-dose raltegravir has a lower coefficient of variation, somewhere on the order of 56 to 71%, and it's definitely less affected by food. So we're going to summarize that section by just essentially saying that it's clear that the NRTI component of any ARV regimen is not dictated by the nucleosides. It's by the anchor drugs. And any regimen that contains etravirine, rilpivirine, protease inhibitors, or L-vitegravir should probably be taken with food. And my reason for doing this little presentation about dietary implications is that I think it can impact our counseling with patients to explain, if a person's on a very low-fat diet, that there is some negative potential to that, especially for the integrase inhibitors. So that concludes that first section. The next slide takes us into a review of drug-drug interaction mechanisms, and they can, be broadly categorized into two types, pharmacodynamic and pharmacokinetic. The pharmacodynamic are certainly there aren't as many of those potential for them, but we know not to use drugs that have an additive antiretroviral effect. We generally use drugs that work well together. So it would be drugs that exert an additive or an antagonistic pharmacologic effect. But most drug-drug interactions are pharmacokinetic in nature, and that happens when one drug generally enzymatically induces or inhibits absorption, distribution, metabolism, or excretion of another drug. And this particular slide we could spend a whole hour on. However, we'll spend about 3 minutes. It's clear that the mechanisms involved in pharmacokinetic drug-drug interactions primarily include induction or inhibition of two types of enzymatic processes. There's the cytochrome P450 and the phase 2 conjugation enzymatic reactions, as well as the induction and inhibition of transmembrane proteins that regulate the transport of small molecules across epithelial membranes located throughout the body. But most significantly, in the small intestines, the liver, the proximal tubules of the kidney, and along the blood-brain barrier of the central nervous system. Roughly 50% of all drugs administered are metabolized by the cytochrome P450 system. It's literally ubiquitous. It's impossible to know all the potential drug-drug interactions that can occur, but we can certainly develop a good system of knowing when to check for those. And I strongly recommend that we have a mental sort of checklist of red flags anytime we are using HIV meds and I would list first any psychotropic medication. That could include antidepressants, mood stabilizers, anxiolytics, hypnotics, the classic or the atypical antipsychotics, any steroid or sex hormone therapy, any opioids, any anticoagulants, any antifungals, any of the new Hep C direct-acting antivirals, any antibiotics, any chemotherapy agent, or transplant rejection meds. It's quite a lot of meds, so we have a major challenge. We also should remember that for phase 2 conjugation pathways like UGT, the glucuronosyl transferase enzyme, it's UGT induction by the rifamycins rather than any kind of cytochrome P450 induction that leads to the need for the dosage change, essentially a doubling of the dose of dolutegravir and raltegravir. And we should also remember for the transmembrane transporters, which most of the time involves P-glycoprotein, but could involve other transmembrane proteins. P-glycoprotein inhibition affects TDF actually more than TAF because TAF achieves a 91% lower plasma level. However, PGP induction, it's more likely to be a problem for TAF for the very same reason, because it has much lower plasma levels. So I think we have some tremendous challenges when it comes to monitoring and addressing drug-drug interactions with ARV meds. Our patients are getting older. They're, developing multiple comorbidities with increasing polypharmacy. There's a lot of direct-to-consumer advertising that encourages our patients to try alternative meds. And I don't know about you, but I see patients just religiously devoted to their alternative meds, even though there's very little evidence to support their use, as well as OTC drugs. Our patients aren't exempt from the challenges we face with illicit drugs or the opioid epidemic. And so we have to ask ourselves, are we really prepared to address the potential drug-drug interactions that affect antiretrovirals? So what I'm going to do is give everybody an end-of-the-year pop test. So today's test includes 2 cases. The first case is Mary Jane. I think everybody's going to make 100 for sure. Is a 26-year-old female. She's pregnant. She's in her 2nd trimester. Her HIV is well controlled on twice daily raltegravir and FTDF, and she has significant symptoms of acid reflux, and she wants to know if she can take an OTC antacid to treat it. So how would you advise this patient? And I propose some answers. The first would be, it doesn't really matter which OTC antacid you use, just choose one that you like to take and that works well for you. Or maybe you should only take an H2 blocker like famotidine or ranitidine and use standard dosing up to twice daily. Or you could use the H2 blocker or possibly even Tums as needed. Or maybe just recommend aluminum magnesium containing antacids in the liquid form because they work quickly. So we'll just pause for 3 seconds. What do you think would be the best answer? I think the best answer is clearly either the H2 blocker, their pregnancy category B, or calcium carbonate, which is Tums. And for the twice daily raltegravir, that is a reasonable option. And we'll look at the discussion points on the next slide. So remember, the bioavailability of the INSTI drugs is not adversely affected by acid suppression. That's important to remember. And actually, the twice daily raltegravir is better absorbed at a more alkaline pH. It's also interesting to remember that the major drug-drug interaction with the INSTI drugs is chelation with cations. And dolutegravir and elvitegravir, we really need to stagger the administration with all cations. For high dose raltegravir, the calcium carbonate antacid is contraindicated. However, with twice daily dosing, and as in this case, we can certainly do it. Also, for high-dose raltegravir and twice-daily raltegravir, we should avoid aluminum and magnesium antacids altogether. But the most important thing to remember with regard to acid suppression is that it is a major issue for rilpivirine and atazanavir. All right, this is our last case. Misty Dawn. That's a drag queen name. She's a 53-year-old drag queen who still performs at a local nightclub. She's been treated for HIV for more than 25 years. Actually, it's a he, has mild hypertension, prediabetes, but no other significant comorbidities. He's physically active, practices yoga regularly. His PCP has prescribed lisinopril for his hypertension and metformin for his prediabetes. And his HIV is well controlled on ECF-TAF. And he tells you today that he's concerned about his weight gain because he can't fit into his gowns at the club anymore. And he's also very tired and says he has chronic sinus congestion. So what's the best question to ask Misty Dawn? I propose some. Do you have problems with headaches associated with your sinuses? And do you take OTC meds like Advil and Motrin? And if you do take those OTC meds for headaches, do you drink plenty of fluids throughout the day? And did this weight gain happen after starting lisinopril, or are you using any OTC nasal sprays? And we can pause for 3 seconds. But I think everybody should get this one. Is the OTC nasal sprays issue. I think we've talked about this probably ad nauseum, but it never hurts to talk about it again. I actually, unfortunately, had a case where I missed a particular incidence of fluticasone with boosted atazanavir. The discussion for this case is that have to remember that both Cobi boosted and ritonavir boosted regimens, in this case it's ECF-TAF, inhibit cytochrome P3A4. And when you administer one of those regimens with steroids, and the steroids are substrates for CYP3A4, patients will most likely develop significantly elevated plasma steroid levels, which leads to, of course, to adrenal suppression and potentially Cushing's syndrome. But in doing the research for the presentation, I realized that it's not just the CYP3A4, but there are other factors that might affect that risk for the drug interaction. And those are whether the steroid has a lower relative steroid receptor binding affinity, whether it has a lower oral bioavailability, whether it has a higher plasma protein binding potential, whether it has a shorter elimination half-life, and also if it has a lower lipophilicity, then it'll have a lower risk for causing this drug interaction. Of the steroids available over the counter, and one is on prescription, those that we should avoid, of course, are fluticasone, budesonide, mometasone, triamcinolone, and all of those are OTC except for the Nasonex mometasone. The safer alternatives, as we've discussed before, is beclomethasone and flunisolide. So that concludes that case. And then there's just some parting thoughts on the last slide, which just acknowledges that, addressing ARV DDIs is a really challenging task. And, it's something that requires, I think, pharmacists and providers, medical providers, to work closely together to try to monitor for and to use online databases as effectively as we can, because these regimens can be so complex. And the databases that I have referenced and like to use are listed there. I think probably the one I like the best is Micromedics, but realize that they're not all created equally, and I strongly recommend using multiple references just to double check to make sure something isn't missed. And I came across an instance recently where that actually happened. So thank you very much for the time.